All right, everyone, welcome. Let's talk ATLS. If you're prepping for your exams or just want that high-yield refresher, you are in the right place. We're going to cut right to the chase and break down the core principles you have to know to succeed. So let's get into it.
Okay, here's our game plan. We're going to start with the why, the whole concept of the clock on trauma. Then we'll hit the absolute bedrock of ATLS, the ABCDE primary survey. After that, we'll dive into those deadly chest injuries you can't afford to miss, figure out how to approach the abdomen, and then talk imaging, fast versus CT. And to wrap it all up, we'll nail down those core principles that'll get you points on the exam.
So, let's kick things off with the big picture. You might wonder, why is ATLS so rigid, so algorithmic? Well, it all comes down to one thing. We're in a race against time. The entire protocol is designed to beat the clock on trauma mortality. If you get this timeline, you'll understand the why behind every single move we make. Now, this slide is absolutely fundamental. You have to understand this concept. See, trauma deaths don't just happen randomly. They cluster into 3 distinct peaks. The first peak, that's almost immediate. We're talking catastrophic injuries to the brain or major vessels. There's not much we can do there. The third peak is way down the line, days or weeks later. Think sepsis, multi-organ failure. But that middle peak, the early deaths peak, that's our zone. That's the sweet spot. These are the patients with a ruptured spleen, a tension pneumo, things we can actually fix. This is where ATLS makes the difference between life and death.
And that brings us right to the heart of it all, the absolute cornerstone of trauma management, the primary survey. I want you to think of this less as a checklist and more as an unbreakable algorithm. It's designed from the ground up to find and fix the things that will kill your patient first. And this right here, this is the golden rule. It's the whole philosophy in one sentence. You treat life-threatening conditions immediately as you find them. What does that mean? It means you don't just keep going down the list. If you're on A for airway but you see a catastrophic hemorrhage, that's a C problem. You stop. You fix the bleed, then you go back to A. Find it, fix it, then move on. It's that simple.
So let's walk through the ABCDEs. A is for airway, and you'll notice it's always paired with C-spine protection. We'll come back to that. B is breathing. Is the chest rising? Is the trachea in the middle? C is circulation, which really means hemorrhage control. Find the bleeding, stop the bleeding, get IV access. D is for disability. This is just a quick and dirty neurological check. You can use the AVPU scale. Are they alert, responsive to voice, responsive to pain, or completely unresponsive? Or, of course, the GCS. And finally, E, exposure and environment. You've got to get the patient undressed to see everything, but the second you do, you have to cover them back up. Preventing hypothermia is absolutely critical.
Okay, let's circle back to A for a second, because this is a huge exam red flag. When we say airway with C-spine protection, that's not just a nice idea, it's a hard and fast rule. If a patient has any significant trauma above the clavicles, a head injury, a facial injury, you must assume they have a C-spine injury until it is proven otherwise. That means full immobilization, no exceptions. This is one of those points they love to test.
All right, here's critical contraindication number 1. This is a total classic exam trap, so listen up. You see a patient with signs of a basal skull fracture, the classic raccoon eyes or bruising behind the ear, battle sign. The question asks about gastric decompression. The one thing you do not do is put in a nasal gastric tube. Why? Because that fractured skull base means you could literally pass that tube right up into the brain. It has happened. So what's the right answer? Orogastric. Always orogastric in this situation.
And here's the other big one they'll try to catch you on, urethral injury. Before you even think about putting in a urinary catheter, you have to check for 3 specific signs. Number 1, blood at the urethra meatus. Number 2, a big perineal hematoma. And number 3, a high riding or boggy prostate on your digital rectal exam. If you find any of those, you stop. You don't jam a catheter in there. The next step is a retrograde urethrogram to figure out what's going on. Okay, this flows perfectly from our ABCDEs. When you're on B for breathing, you're not just looking, you are actively hunting for a specific list of killers. We call them the lethal thoracic 5, and you have to be able to spot them and manage them instantly.
Look, this table right here, this is exam gold. You should basically have this memorized. It's all about pattern recognition. Let's run through them. You see a patient with a deviated trachea, hypotension, and absent breath sounds? That's a tension pneumothorax. Your immediate move? Needle decompression followed by a chest drain. You see a big sucking chest wound? That's an open pneumothorax. You slap a 3-sided dressing on it. Massive hemothorax. We're talking 1.5 liters of blood comes pouring out of the chest drain. You need that drain in, but you also need to be thinking about a thoracotomy, stat. Flail chest, that's all about support.
oxygen, good pain control, maybe even positive pressure ventilation. And finally, cardiac tamponade. Think Beck's triad: muffled heart sounds, hypotension, JVD. Your move is pericardiocentesis. You have to know these 5 pairings, no question about it. All right, we've dealt with the airway, we've dealt with the chest, now we're moving down to the abdomen. And the first question you have to ask yourself is, how did this injury happen? Because the mechanism, blunt versus penetrating, tells you a whole lot about what you should be looking for.
These are pure, high-yield facts for your exam. For blunt trauma, say a steering wheel to the abdomen, the most commonly injured organ is the spleen. For a stab wound, it's the liver. For a gunshot wound, it's the small bowel, just because it takes up so much space. And for those big deceleration injuries, like a high-speed crash, you've got to have a high index of suspicion for things like mesenteric tears and even aortic injuries. Now, here's a massive clinical pearl: the pelvis. If you think there's a pelvic fracture, you check for stability 1 time. Just a gentle push, that's it. If you keep rocking it, you can dislodge a life-saving clot and cause a catastrophic bleed. Check it once and document it. So, you're pretty sure something is bleeding in the abdomen. Now what? How do you figure it out? Well, the patient's vital signs are going to dictate your next move. This is where you have to make a critical call. Which imaging tool do you reach for? And really, it all boils down to one simple question: is your patient stable or unstable? If they're unstable, hypotensive, tachycardic, they are too sick to leave the trauma bay for a CT scan. That's where the fast scan comes in. It's quick, you can do it at the bedside, and it tells you one thing: is there free fluid, aka blood, in the belly? On the other hand, if your patient is hemodynamically stable, then the CT scan is your gold standard. It'll show you exactly which organ is injured, it can see retroperitoneal bleeds that the fast scan might miss, but it takes time and requires moving the patient. So, unstable patient gets a fast scan, stable patient gets a CT. It's a fundamental concept.
Okay, let's pull all these threads together. We've gone through the whole sequence, from the timeline to the abdomen. Now it's time to boil it all down into your final checklist, the absolute core principles you need to have locked and loaded for exam day.
All right, here we go. Rapid fire. Number 1, priorities first. It's always life before limb and airway before a fancy diagnosis. Number 2, stop the bleed. Catastrophic hemorrhage trumps everything. Number 3, be systematic. Do not deviate from the ABCDE sequence. It's your safety net. Number 4, know your tools. Understand the role of FAST, CT, and even DPL. They are not interchangeable. Number 5, think ahead. Anticipate the deadly complications like hypothermia or an arrhythmia from a whack to the chest. And last, but definitely not least, this is a team sport. Clear communication in a trauma team isn't a soft skill, it is a life-saving procedure. Got it?
So we've spent all this time mastering the perfect algorithm. It's clean, it's logical, it saves lives on paper. But I want to leave you with one final question to think about. Now that you know the system inside and out, what do you think is the single biggest threat to making it work in the real world, in the chaos and pressure of a real trauma bay?